Ladies and gentlemen, dear friends, welcome again on ISGE webinar. This is the first webinar that we start in preparation of our next 2022 World Congress in Florence. This webinar was supported by Dr. Wolf Group and is dedicated to a very important approach in gynecology, which is the hormone-free therapy for vaginal dryness. Is that possible? And the data will be based on a clinical evidence of a series of investigations done by our speaker. And it's my pleasure to introduce you Professor Petra Stute and Professor Camille Castello-Branco. Professor Petra Stute, she is the head of Menopause Clinic and Gynecological Endocrinology, Deputy Head of Gynecological Endocrinology and Reproductive Medicine Section at the Department of OBGYN of Inselspital in Bern, Switzerland, and she is President of the same time of the Swiss Society of Gynecological Endocrinology and Menopause and Swiss Society of Applied Clinical Biochemistry. And she's board member and treasurer of the German Menopause Society. The second speaker of this afternoon is Professor Camille Castello-Branco, which is Professor of Obstetrics and Gynecology at Barcelona University in Spain, and he is the head of the surgery department and the Obstetrics and Gynecology teaching unit at the University of Barcelona, and is director of the Gynecological and Endocrinology unit at Hospital Clinic in Barcelona, and is a former chairman of the Council of Associated Menopause Society of our International Menopause Society. And she's a very important member since many, many years of the International Society of Gynecological Endocrinology, as also Professor Petra Stute she is. And then now we will start with the first lecture. The first lecture will be done by Professor Petra Stute, and the title is Hormone-free vaginal cream proves superior efficacy to a vaginal gel and not inferior to an estriol cream. Clinical evidence. Please, Petra, you have the microphone.
Yes, thank you very much, and welcome from the OBGYN department in cold and rainy Switzerland. And as you've already been told, I'm starting with a statement. So it's not a question, it's a statement. Hormone-free vaginal cream proves superior efficacy to a vaginal gel and not inferior to an estriol cream. So let's have a look at the clinical scientific evidence if this statement is true. So when estrogens decline due to menopause, there are several changes occurring to the vagina wall. For example, the vaginal epithelium is thinning, and as a consequence, the exfoliation of the vaginal epithelium goes down. And with this, also the glycogen production is reduced. However, the glycogen is a substrate for the lactobacilli. So as a consequence, the number of lactobacilli is also reduced, and thus the production of lactic acid. As a consequence, vaginal pH increases, and furthermore, there may be an overgrowth of other bacteria leading to a vaginitis. However, it's not only showing some objective changes to the vaginal wall, also the women that are affected by estrogen deficiency due to menopause are suffering from several genital symptoms, such as dryness, itching, burning, dyspareunia. And all these kind of symptoms may lead to a reduced quality of life and to a reduced sexual health of affected women. So now you may wonder how often these symptoms may occur in menopausal women. And actually, from these international surveys, we have learned that indeed vaginal dryness is the most frequent vaginal symptoms that does occur in menopausal women. And up to more than 80% of women report vaginal dryness due to menopause, which is followed in frequency by dyspareunia and itching. And this has been found in Europe as well as in the US. And of course, these kind of symptoms may have an impact. And about 50 to 80% of women report that vaginal discomfort has a negative impact on their quality of life and also on their sex life. Now, you may say, well, that's no surprise because we as physicians, we are quite aware that vaginal symptoms may be part of menopause. However, this is not so clear for the women that are affected by these symptoms. So again, from the international surveys, we know that only a minority of about 40% of women are aware that vaginal symptoms may be associated with menopause. And even less women are aware that vaginal symptoms may be part of something we call genitourinary syndrome of menopause. And on the other hand, women do need a lot of information about genital or vaginal symptoms. And again, if we have a look at the international surveys that have been performed, we know that a lot of women want to discuss their symptoms with us, their healthcare professionals. However, we are not really helpful in this situation because only few physicians are actually initiating the conversation about vaginal symptoms. So there's a huge gap between the needs of women that want to know more about vaginal health, and on the other hand, our not so being interested in discussing this topic. So, and as this, there's no surprise that the current treatment of most women is, let's say, suboptimal. So there are several kinds of treatments available. Some of them are also free, which means they can be bought over the counter. And that's probably the majority of women that are helping themselves by just buying anything. However, if we have a look again at the survey coming from the US and from Europe, we can see that there's a huge number of women that actually do not get any treatment at all. And only a minority of women is treated with hormones, for example. And this is quite a discrepancy because if we now have a look at the most recent position paper by the North American Menopause Society, which was published in September 2020, we see that there is a variety of treatment options available for women suffering from GSM. So we have vaginal estrogens, we have vaginal DHEA, we have in some countries also the selective estrogen receptor modulator ospemifene, and we have tons of, okay, maybe not tons, but we have a lot of non-hormonal products. And if we have a closer look at the NAMS position paper, then we will read that actually the non-hormonal therapies are first-line therapies to treat genitourinary syndrome of menopause. And we have two different kinds of non-hormonal therapies. We have the vaginal lubricants and we have the vaginal moisturizers. So the vaginal lubricants, they are perfect for a short-term relief of dryness during intercourse. Whereas the vaginal moisturizers, they provide a long-term relief of dryness. Furthermore, the vaginal lubricants may have a temporary increase in skin moisture. However, most of the time they are gels, so they have an unfavorable skin drying effect. On the other hand, the vaginal moisturizers, they have a long-term impact on the skin moisture, so they increase skin moisture in the long term because they can provide lipids. Okay, and this is the topic today. So we would like to focus on non-hormonal treatment, and we would like to focus on non-hormonal cream. And there's one cream available which has a lipid content of 23%. It doesn't contain any hormones, and it's applied weekly during the first day and as often as you wish afterwards. It can be applied intravaginally, and of course, it can also be applied on the external area of the genitals. And I would like now to present the 2 studies that have been performed so far with this free of hormone moisturizing cream. And in the first study, this non-hormonal cream was compared to a non-hormonal vaginal gel. And in the second study, the non-hormonal vaginal cream was compared to a conventional estriol vaginal cream, which is quite frequently used, for example, in Europe. So both studies were prospective, open-label, multi-center, randomized trials. The first one was a changeover trial, and the second one was a parallel group trial. And the duration of the first study was 4 weeks, and the duration of the second study was 6 weeks. And in the first study, peri and postmenopausal women were included, whereas in the second study, only postmenopausal were included. And the age was around the mid-50s. The aim of both studies was to assess the efficacy and the tolerability in patients with vulvovaginal dryness. And the
Yes.
primary objective was to prove hormonal gel, and the objective of the second trial was to prove non-inferiority of the hormone-free cream versus the estriol cream. Okay, and let's have a look at the results. But first, we have to know what kind of endpoints we were looking at during these studies. So definitely we had to look at subjective symptoms like dryness, itching, burning, pain, dyspareunia. And the women could score each symptom on a scale from 0 to 4. And of course, we wanted to know if those subjective symptoms have an impact on daily life. So again, the women could score their impairment of daily life from 0 to 10. And 10 equaled a very strong bad impact on daily life. Then we also had to assess objective signs. And in the first study, where the cream was compared to the gel, objective signs were assessed by a score. And this score assessed the parameter thickness, redness, bleeding, discharge. And in the second study, the vaginal health index was used as an objective sign score. And in this vaginal health index, the parameters elasticity, fluid secretion, pH, mucosa, and moisture were assessed. So now we go and have a look at the results. I will present to you 2 slides on the subjective symptoms, 2 slides on the objective signs, and then 3 slides on daily impairment or the impairment of daily life, and a final slide on dyspareunia. Okay, let's start with the subjective symptoms. On this slide, you can see the total severity score of women in these 2 studies, and the total severity score was a subscore, which included the 4 different subjective symptoms. On the left side, you can see the comparison between the non-hormonal cream and the non-hormonal vaginal gel. And on the right side, you can see the comparison of the non-hormonal cream to the estriol cream. And the pink line is always the non-hormonal cream. Okay, what can we see on these slides? First of all, we can see that within 1 week, the total severity score in both studies came down. What we also see is in the first study, comparing cream to gel, that the cream was superior to the gel in decreasing the total severity symptom score. On the right side, we can see that the non-hormonal cream was not inferior to the estriol cream in decreasing the total severity symptom score. Now we focus on the comparison non-hormonal cream to vaginal estriol cream. As we've already said, a lot of women had an improvement of the total severity score, what we can see on the left side in the two bars. So up to 100% of women had an improvement of their symptoms. If we now have a closer look at each symptom like dryness, itching, burning, pain, and dyspareunia, we can also see that both treatments, the non-hormonal cream and the estriol cream, led to an improvement in all kind of symptoms. Now we have a look at the objective signs, and I would like to start with a study that compared the non-hormonal cream to the non-hormonal gel. And on the left side, we can see the change of the severity of objective signs. You remember, this was a composite score of thinning, redness, bleeding, and discharge. And what we can see on day 1, that both treatments were quite similar. However, 1 month later, the whole situation had changed. And what you can see here is that after 1 month of treatment, the objective signs had significantly improved in the non-hormonal cream in comparison to the non-hormonal gel. If we have a look on the right side now, we can also see that the vaginal pH significantly decreased after 28 days of treatment with the non-hormonal cream. However, in the treatment group of non-hormonal gel, there was no change of the vaginal pH. Now we look at objective signs in the trial that compared non-hormonal cream to the estriol cream. And you remember, in this trial, the vaginal health index was used as an objective sign score. And again, if we have a look at the bars here, we can see that the estriol cream and also the hormone-free moisturizing cream had a positive impact, so a improving impact on the objective signs. However, in this study, we can see that the estriol vaginal cream was significantly better than the non-hormonal cream in respect to improving objective signs of vaginal atrophy. Now we switch to the impairment of daily life. And this is again the study comparing the non-hormonal cream to the estriol cream. And this example you see here first is the area under the curve for the symptom dryness. So what we can see here is that after already 7 days of treatment in both treatment groups, the impairment of daily life is lowered. And this treatment effect goes on until more than 42 days. And what we are doing here is looking at the area under the curve. And now, if we also have a look at the other symptoms and their area under the curve, we can also see that it's not only the vaginal dryness which is improving in context of daily life impairment. It's the same story for itching, burning, and pain. And we see here that there's no difference between the non-hormonal cream and the estriol cream in this respect. So what we can see here is that indeed the daily life impairment is decreased by both treatments compared to baseline, and that a huge number of women is actually reporting an improvement of their daily life impairment due to subjective symptoms in both treatment arms. If we do a little bit of sub-analysis and we think about, maybe there's a difference if the women at baseline have very mild vaginal dryness or if they are really suffering from severe dryness. And what we can see here is indeed that if women are having only mild or moderate vaginal dryness to start with, then both creams, the hormone-free cream and the estriol cream, they are similarly effective to treat vaginal dryness. However, if a woman is really suffering from severe vaginal dryness, then we can see that the vaginal estriol cream is more effective than the non-hormonal cream in reducing or improving vaginal dryness. So the final slides I wanted to show you is symptom of dyspareunia. So what we can see here is, again, both creams, either without hormones or with hormones, is improving dyspareunia dramatically. And this is also true for the impairment of daily life that women have due to dyspareunia. And if we have a look at the severity score of dyspareunia, we can also see that the severity score of dyspareunia was positively impacted by both creams. Okay, now at the end, after I've told you so many good things about the non-hormonal creams, of course you're wondering, what can be bad about this vaginal cream? So what are the adverse events? And of course, like in all studies, you will have several adverse events. But if you have a closer look, you will see it's most of the time it's local irritation, which means like vaginal burning maybe at the beginning, or an irritating sensation. And if we have an overall look at the vigilance data that have been assessed with the non-hormonal vaginal cream, we can say that there is on average 4 adverse events per 100,000 packages sold. And most of the time, the adverse event is a burning or itching sensation at the application site. So to come to the conclusion. So indeed, we were able to prove a statistically significant superiority of the non-hormonal cream compared to the vaginal gel. And we could see that there is a statistically significant non-inferiority of the non-hormonal cream versus the estriol cream. So now we know that the non-hormonal moisturizing cream can significantly improve subjective vulvovaginal symptoms due to menopause. It's also having a significant improvement of impairment of daily life. And if we have a look at the objective signs, then compared to the vaginal gel, the non-hormonal vaginal cream is superior to the gel. However, if we look at the comparison between non-hormonal cream to estriol cream, then the estriol cream is still superior to the vaginal cream, non-hormonal cream, in the context of vaginal health index. And what we also could see, the safety profile is excellent. And with this, I would like to thank you for your attention, and I give back to you.
Thank you. Thank you very much, Professor Stute. And thank you, Petra, for the beautiful presentation. We will now move to the presentation of Professor Camille Castelo-Branco from Barcelona, which is touching a very crucial area in his presentation, which is the breast cancer survivors also benefit for hormone-free vaginal cream for the treatment of their vaginal dryness. Please, Camille, if you can share your slide. And if
Thanks,
you can...
Andrea, for your kind presentation. And
yes, you go in
here.
Yes, thank you. Perfect, perfect. Thank you.
So thanks, Andrea, and I appreciate you taking the time to stay with us at this webinar today. Friday sounds like a wonderful time to go away, but also to learn, and I am excited about the opportunity. Thank you in advance for your assistance. This I expect interesting webinar for you. As all of you know, this is a sponsorized webinar by Dr. Wolf Group, and this is the summary content of the present lecture. Breast cancer is diagnosed in millions of women worldwide each year. The incidence rate continues to climb. Encouragingly, new therapeutic alternatives are quickly emerging for patients. This rapidly evolving landscape means that many previously accepted notions about risk, prognosis, and treatment are also changing. It's estimated more than 2 million new cases of breast cancer occurred worldwide among women last year. The overall survival of women with breast cancer has increased over the last decades, despite the increasing prevalence of this disease. And this slide illustrated this condition. In parallel with the increasing incidence, the survival rates are also increasing. And nowadays, the treatment of breast cancer for most of patients is designated with a curative intention. Many breast cancer survivors are still of premenopausal age and have the potential risk of receiving antineoplastic treatments that may affect ovarian function or antiestrogenic drugs that mimic a postmenopausal state, becoming evident clinical manifestation of the related hypoestrogenic state. And many patients will complain with symptoms of vaginal dryness as a side effect of tumor therapy. In these cases, the collagen and water content of the vaginal mucosa decrease. It becomes less elastic. The epithelium becomes thinner, redder, and easily injured, and petechial bleeding is possible as occasional discharge. The sustained hypoestrogenic state of the vaginal epithelium increases the potential for developing symptoms of dryness, itching, burning, and pain, and consequently, painful sexual intercourse. All these symptoms can significantly impair the overall quality of life. Breast cancer survivors have many reasons for presenting sexual problems, from the stress of diagnosis to the different therapies and its adverse event. Many areas of their sexuality may be involved, including not only the genital affectation. In fact, patients with breast cancer, after diagnosis of breast cancer, have up to 17 times more risk to present climacteric symptoms. And among them, those who are receiving antiestrogenic therapy increases this risk 3 to 6 times more over these 70 times. So the picture is a big concern. Up to 75% of breast cancer survivors present one or more genitourinary syndrome of menopause symptoms. And despite these bothersome complaints, few women discuss with the physician or seek gynecological care, in part due to embarrassment, lack of knowledge, and awareness of the menopausal change. Finally, other women expect a scan or no support from their doctors, considering that for many healthcare providers, this is not an important issue. All these changes associated with BBA are related to many other emerging problems, such as sexual and mood disorders, relationship problems, reducing well-being, etc., that leads to emotional distress and finally reduced quality of life. Therefore, it's imperative for clinicians and both ask both women with partners and without about potential physical change and alterations that can be related to BBA. As Professor Stute comments before, in general, but especially for high-risk patients, lubricants and moisturizers are the first line of therapy in the management of BBA. And the study product that has been previously presented by Professor Petra Stute is one of them. Through the addition of lactic acid, the pH of the cream is 4.5, and as such, the moisturizing cream helps to maintain the natural pH level in the vagina. Two effects combine to enable this product to alleviate the symptoms of BBA. First, the cream has a high water content, and accordingly, the mucosa and the skin in the vagina and the external genitalia is supplied with moisture. And second, nurturing lipids help to keep the skin smooth and supple. And importantly, this product, as has been previously commented, is hormone-free, but also is paraben-free. Parabens, as all you know, are an important endocrine disruptors that are present in many moisturizers available in the market. And now it's time to present the clinical trial on the efficacy and tolerability among breast cancer survivors complaining with BBA. This study has several limitations. However, the study population are undergoing breast cancer treatment, being an orphan group of patients in relation to the management of BBA. The product has been previously presented, and the posology and administration in this study was the same that in the previous studies exposed by Professor Petra Stute. Subjective symptoms and objective signs were recorded by patients and gynecologists respectively, and scored from 0 to 4, being the maximum score of 16 in both cases. Additionally, adverse events were recorded, as well as the global assessment of efficacy and tolerability by patients and their physicians. This is similar to the other studies previously presented by Professor Stute. Most of the women included in this study suffer from symptoms of feeling dryness, itching, burning sensation that after 4 weeks of treatment improve significantly. And in global terms, the reduction of the total score of subjective symptoms exposed by patients in their questionnaires was over 70%. Of the total of 117 women included in the initially in the study, 89 were sexually active at the beginning of the study, and 75 declared painful sexual intercourse at the beginning. At the final of the study, only 35, a reduction of 50% of the women, had still dyspareunia when we're asked about this condition. And after 4 weeks follow-up, most of the women refers no pain at all or just in rare occasions. It's noteworthy that each individual subjective symptom was improved across the 4 weeks follow-up. An improvement in objective symptoms was also observed, and is to note the highly significant reduction in the percentage of women suffering from redness and petechial bleeding. Regarding tolerability, most of the subjects, close to 90%, did not present any adverse event, being transient itching or burning the most frequent one. This is similar than the adverse event exposed previously in the previous lecture. And finally, regarding the global assessment of the treatment, most of the patients had their health providers scored efficacy and tolerability as very good or good. In summary, this hormone-free moisturizing cream in breast cancer survivors has demonstrated statistically significant improvement in subjective vulvovaginal symptoms, a statistically significant improvement of dyspareunia, also improved objective signs, and all of this action with a very good profile of efficacy and tolerability. Well, thank you for your attention and your kindness remaining in this webinar instead to begin the weekend. Thank you very much.
Thank you, Camille. And I would like to ask also, thank you, Petra, if you can open your microphone. We will start now for the discussion. We had several questions. I start with one that I will give you the answer. It was for Dr. Vasquez. He asked about the osmolarity of the lipid cream, and the osmolarity is 37.4 milliosm per kilogram. This is just to give you the answer. And then I will start with question, dividing the question between Petra and Camille. I will start with Petra, women first, and thank you. And I will ask you, what is the difference between a gel and a cream? If you can go more in details on that point.
Yes, thank you. I'm very happy to answer this question. So cream and gel, they are both oil in water emulsions, emulsions, and but the content of the water is different. So this means in a cream there is less water in comparison to a gel. And for the clinical, from the clinical perspective, this means that a gel can have, because it has a higher water content in comparison to a cream, so a gel can have a more cooling effect, which sometimes is what someone wants. But on the other hand, it's also has a it dries more quickly. So this means you put it on somewhere, and then you more quickly have the impression that it is dry and not creamy anymore. And compared to that, a cream which has a lower water content compared to the gel, because it has more lipids, it has a more soothing effect. It's not so much cooling, but usually that's not necessary within the vagina, but it has a more creamy and soothing effect compared to the gel.
Thank you very much. And then we have one anonymous question. This is for Camille. You have given several reasons describing why some women doesn't explain their genitourinary syndrome of the menopause complaints to their doctor. However, sometimes are the doctor then maintain the silence. What is the opinion?
Well, this is an important question, the silence of healthcare providers. Reasons for this silence include different beliefs from doctors. Some think that someone else will do it. Others that patients never ask about it, so they must not care of this problem. Others don't know how to help or don't have time, so don't ask, or don't agree with their lifestyle, or think that they are that the patient should be happy to be alive. Others think that the patients are too old, too sick, too young, etc. Or think that maybe will be often the patients if they ask. And these attitudes occur in spite of that most of the oncologists recognize the impairment of BBA and the negative impact in sexuality, as was demonstrated in a survey made by Nicoletta Biglia, in Italian oncologists. More than 120 Italian oncologists were surveyed, and all of them recognized that BBA was an important concern for patients, but less than half explained the adverse events of the antiestrogenic therapies to their patients. And among the oncologists who explained the negative effect of BBA, less than a third managed the BBA of their patients. So there are many beliefs in the doctors for don't ask, but even in the doctors that are concerned about this problem, most of them don't do nothing.
This is the reason of our webinar. And then now we have a question from a friend of us. I thank him to be with us. It's Steve Goldstein, which is the president of the International Menopause Society from New York. He's from Professor Stute. Thank you for this most interesting study. The data comparing hormone-free cream to estriol is interesting. However, estriol is not FDA approved in US. Is there any data comparing the cream to the available methods of delivering vaginal estradiol?
Okay, you're right that in the US, estriol is not approved for vaginal atrophy treatment. However, it's approved in Europe since, I would say, ages, and it's more frequently used than vaginal estradiol. However, there are no studies directly comparing the non-hormonal cream to the vaginal estradiol, but this is most likely due because when the study design was put together, of course, the comparator should be something that is very frequently used also in Europe. And as I already said, in Europe, vaginal estriol is much more often used than vaginal estradiol. And we have much more products available, like creams, suppositories, gels, whatever, everything with estriol. So it was very, very obvious that estriol had to be the comparator.
Thank you, Petra. And then for Camille, a question from Iman Ahmed. For how long we can use the non-hormonal cream?
Oh, the answer is easy and fast. all the time that are needed.
Yes, thank you very much. And also another one, any comparison with CO2 laser from Eau de Béliard?
Well, laser is an emerging therapy and a promising therapy too. We are, in fact, we are developing a study with a comparative study with laser plus an hydrogen and a moisturizer, and sham laser with a moisturizer. We expect at the end of this year to can present the results. But as laser is for breast cancer patients is really an interesting option.
Thank you very much. And also for Petra, again, a question also, which is what are the ingredients of the cream? And then I would like to mention the name of that cream that you were using. What are the ingredients?
So I think the most important ingredients are the lipids. So we have 23% of the content are lipids, and it's also lactic acid in there. And the lactic acid is able to reduce the vaginal pH, which of course has a positive impact on the vagina health and helping to defend the vagina.
Thank you. And now for Camille, a question from Selva Lima. For breast cancer survivor, you choose cream with estriol or without hormone. Thanks for presentation to both of you. But just to Camille, what you are really using in your daily practice?
Well, without hormones.
Without hormones.
Without
okay.
hormones, and as I have commented previously, now we are developing a study with laser for these patients.
And also a question was raised about in which countries is that cream that you are speaking today, because we have to tell this was a webinar organized by Dr. Wolf Group, and then in what countries that cream, that moisturizer is available?
I think in 24 countries.
In 24 countries. Okay, I don't want to name each one of them, but okay. Also, this question was also for Petra. And another question. Okay, a question is that one is interesting. It's an anonymous participant. Often subjective signs of improvement have a high placebo effect. Do you think there is a limitation in these studies where a placebo arm was not included?
Well, of course, it's always good to have a placebo arm, but on the other hand, a placebo arm also has to have anything in it. So, and then the placebo arm is not a complete placebo arm anymore. And I think this is why when comparing two non-hormonal products to each other, that's already a challenge. And that's also probably not easy to conduct, because you really have to show a difference between two non-hormonal products. That's not as easy, I would say, as when you compare non-hormonal products to vaginal estrogens. So this is why I think, of course, it's always good to have a placebo arm, but in most studies that are using placebo in, let's say, comparison to an estriol cream, then the placebo is just a cream without the estriol, and then it's comparable to our non-hormonal cream again.
Thank you, Petra. And now for Camille, Mangalore Damodar Kini, she's asking, breast cancer patients, can they use estriol cream as it is locally absorbed, or does bypass the liver?
Well, this is a concern for most of the oncologists and patients too. In fact, we are developing another trial with prasterone in breast cancer patients in a unit. And as you know, prasterone theoretically don't increase estradiol levels, but patients are afraid to use, and in fact we have difficulties in the recruitment for this specific study. So the term of hormones for oncologists is not bad, is able, and for patients are very concerned.
Yes.
In fact, we can use if we are patients with tamoxifen, for in example, that don't respond to other measures to treat BBA. In patients with tamoxifen, we can use a local cream of estriol, but in general terms, I don't use.
Thank you very much. And then now one question, Petra, for you, for Ludwig Kiesel, and many friends who are today with us. It's a great lecture. Does the effect of estriol cream decrease due to the thickening of vaginal wall with time? And if so, is this clinically relevant?
Okay, that's a good question. And actually, so now when we are talking about vaginal estrogens and the question how sustainable the effect is. And we just published a systematic review on the sustainability of vaginal estrogens. And in this systematic review, we found that after 3 to 4 weeks, after stopping the vaginal estrogens, the objective signs are back to baseline, whereas the subjective symptoms of vaginal atrophy, they remain, or they are stabilized for a little bit longer, for up to 3-4 months. So this means that if you are using vaginal estrogens and you stop using them, then the effect will disappear with time, which is probably not a big surprise, but still the question was how long does it maintain? And on the other hand, as long as you are taking the vaginal estrogens, the impact keeps the same. So it's not that you start and then suddenly it goes down. It only goes down when you stop it, and then it takes some time to the symptoms to come back.
And then another for Camille. How many times the cream could be used in a day?
Well, that depends on the place that we use the cream. For external genitalia, you can use as needed, 1, 2, 3, 4, 8 times per day. But for vagina, the first week, usually the recommendation is 1 time per day. And the dose in all the studies was the same, 2.5 grams. That means half of the filling of the applicator. For external genitalia, the recommendation is a fingertip that represents 0.5 grams of the cream and can be used as needed.
And Petra, another question: what about the efficacy of the non-hormone cream on urinary syndrome of the GSM?
This was unfortunately not assessed in a standardized manner. So the focus really was vaginal subjective symptoms and objective signs, but nothing in the urology, urogynecology section.
Thank you. Then we have the thank from Steve Goldstein, and then another question for Camille. And okay, this is this is from Hector Miki. In a mujer who have no antecedent of breast cancer, what it would be better to use in your believings? And you start with use hormones or cream
Well, the general recommendation is as first line in any case, non-hormonal therapies. But I fall in love with hormones, and I like very much hormones. And for severe cases, I usually start with hormones.
Yes, and you could probably also combine them. You know, if you have a breast cancer patient, she's starting with the non-hormonal cream, and then you would like to add some estriol in Europe, for example, then we have tiny dosages with only 30 microgram of estriol in it. And then you can say twice a week, the very low dose estriol tablet, for example, combined with as much as you want non-hormonal cream.
Thank you. And another question was on the possible use of vaginal platelet-rich plasma. Do you have any experience about that one?
No, I have read, but I have no experience.
Yes. And then also from USA, Corrado Altomare is asking about your experience on ospemifen.
Yeah, we use regularly ospemifen, and we observe not only an improvement in BVA, but not only improvement in vaginal symptoms, but also in the skin. And this is for some women is a very good product.
And then another for you, Camille, the study that you presented at several weakness as short follow-up, open and no control. What are the strengths? Why we should recommend this product for our breast cancer patients?
Well, I must agree with your comment. No, the study has several limitations. The short-term follow-up is usually is actually a challenge to demonstrate efficacy. But in this case, just in 28 days, the product showed the efficacy. Knowing the composition, to expect adverse event at long term is not difficult to occur. Adverse event at long term.
Yes.
And at short term has been presented that are minor adverse events.
Yeah. Thank you.
Another aspect that has been previously common, and Professor Astute has answered previously, is the lack of comparative, a placebo arm in this study. But I am not sure is ethical to give placebo to patients with that complies with a symptom. And this is a question that in many studies is an emerging question for most of the studies, not to give placebo when the patient has a complaint.
Yes.
And on the other hand, a cream with estriol in these patients is for many of these patients is not acceptable, and for many physicians too. Third, and most important, the sample. Now, this sample is composed by breast cancer survivors that are undergoing treatment for breast cancer, or in the first 3 months after finish the treatment, and are receiving antiestrogenic drugs. This is a special group in which symptoms of BVA are increased and may affect severely quality of life of these patients. So they need the main strength of this study is the sample, because we are dealing with patients that has a condition that is usually forgotten for many physicians, as has been previously commented and demonstrated by the study of Nicoletta Viglia.
Thank you. Petra, do you want to make any comment about this point?
No, I'm fine. Thank you.
Thank you very much. We have a question again for you. Is about the use, which is on the breast cancer, but I think you can, Petra, ask about the use of promestrine.
Okay. We do not have it anymore in Switzerland, and we never had it in Germany. So right now we do not use it. And as far as I know from the literature, it still may have a systemic estrogenic effect. So even if we had it here in Switzerland, I would still prefer the approved vaginal estriol products, which have ultra low doses of estriol. And So most of the time is really non-hormonal to start with, then the vaginal ultra low dose estriol products, and then we also have the option of laser, or what Camille already said, of prosterone.
Thank you very much. And then we have received many questions, many requests. What is the name? The name is Vagisan. But if you go in Dr. Wolf group, you can see all details about this product, the countries where it's available, and the efficacy. Okay, then, dear friends, I think we have no more other question. And then I would like to thank Professor Petra Stute, and I would like to thank Professor Camille Castello-Branco, to thank Wolf Group to have supported this important initiative of the International Society of Gynecological Endocrinology, because I want to remind you that hormone and non-hormone treatment are all part of our concern. Thank you very much for your presence. Thank you, Petra. Thank you, Camille. And thank to all our participants.